going to be discussing peripheral vasopressors as my next talk. And, you know, those of us who go through fellowship training, we have to do research, right? And I've never done research in my life. I never really cared for research. I like reading research, right? That's what I do on social media. But actually being part of it wasn't the trick. So one of my attendings like, Eddie, to graduate, you need to do something. And I'm like, well, start throwing ideas my way. And we actually did a paper on using peripheral vasopressors. That's the only thing I've actually published that I actually worked on, instead of just having my name thrown on there. But nonetheless, that's neither here nor there. But I like peripheral vasopressors because even though when we're residents and fellows, we get super excited about placing central lines in people, it gets kind of old, let me be honest. And in addition to that, there's a lot of morbidity that goes towards patients when you place a central line. You know, they're already having the worst day of their life. They're sick, they're in shock, etc. And next thing you know, they're going to get an IV put in their neck. Just the consent process is like, you're going to do what? And is that going to hurt? You know, these are not fun things. So we want to minimize I guess how we could say, we want to minimize the morbidity that we cause our patients. And then there's another, did I break it? There's another component here that we need to think about. And it's the fact that, not working, but it's the fact that placing central lines is a zero-sum game. What I mean by that is the time that you're spending doing the central line, there's also a nurse with you, other ancillary staff who's with you that are not accomplishing other tasks on other patients. We like to think that we're only taking care of one patient at a time, but we know at the end of the day, that is not the case. I think I'm breaking it, guys. Oh, you know what? You started on the last slide. Scroll all the way to the top. Boom. All right, there we go. Boom. There's my zero-sum game thing. And one of the reasons why a lot of people have hesitancy towards placing peripheral IVs is the fact that they think that everybody's going to extravasate, they're going to lose their arm, it's going to fall off, and bad things are going to happen, right? But we need to know that even placing central lines, a triple lumen catheter, whether we do subclavian, IJ, femoral line, these all have complications within themselves. The complication rate of central lines is 1.5%. Whether it be arterial puncture, CLABSIs, whether it be DVTs, etc., we're looking at 1.5% complication rates. What do we see when we place peripheral IVs and use vasopressors through there? Any guesses? 1.8. So the data is not saying, hey, we need to do central lines. We're actually seeing when safely placed and placed under proper protocols, which we're going to discuss, complication rate for peripheral IVs and using vasopressors is not that high. Now, there's also a push towards more early vasopressors. When many of us were busy doing other things in 2020, there were 2 papers that were published looking at benefits of placing patients on peripheral vasopressors prior to placing the central line. In other words, having the patient resuscitated earlier in their course by using vasopressors compared to just tanking them up, then placing the central line, etc. And they showed that patients achieved their hemodynamic stability sooner. But that's not the process, the point of this talk. But what we should do is, if we're going to be using peripheral IVs for vasopressors, is actually protocolize the process. This is what's going to make it safer for our patients. The first thing you want to do is choose an appropriate location. You don't want to put it in the arm where you're going to be doing the blood pressure checks. That's just not going to work out. You also don't want to place it on the foot. You don't want to place it on the pinky finger. That's just not going to work out. The data shows that if you place it in the hand, it's going to be more dangerous than placing it in other places with a 3.1% complication rate. When you choose the rest of the arm, and some data will say you want to use a forearm, some says the antecubital, some say proximal to the antecubital, it's all about 1.9%. That's where the data gets a little bit wish-washy. We could all agree, don't use the hand, but agree that we could use the arm as long as we use it safely. And what do we want to do? Choose the optimal vessel. A lot of us are doing peripheral guided IVs now, ultrasound guided IVs now. And so you want to make sure that the diameter of the vessel is at least 4 millimeters. You also want to make sure that there's appropriate blood return. Okay, so your nursing staff could definitely help you out with that in checking your IV periodically to make sure that there's good flow, make sure that there's good return. Big question. How long could you use peripheral IVs? This is something that's been explored in the data, and there's no prospective study saying, hey, how long can we keep it in there until somebody extravasates? You can't do that, right? So we could use some retrospective data to give us the best guide to what we should be doing. And the most robust data says between 24 to 48 hours. This is possibly even longer than what a lot of you are doing at your respective institutions, but looking through these data, this is shown to be safe. Some data even says up to 72 hours. Now, I will say myself, by 72 hours, I would have placed a midline or a PICC line in the patient rather than just keep it through a peripheral. But 24, 48 hours seems to be safe enough. Next question is, how high could you go on the doses? Honestly, if your patient's on jet fuel, then you kind of need to put a line, you know, like let's stop wasting time with that. But data looking at norepinephrine and phenylephrine, which are usually the most commonly used vasopressors through peripheral IVs, I don't know weight-based dosing. Could you guys tell me, is that a lot? I got told yesterday that wasn't a lot, but that's the highest dose that's noted in the literature. I don't use weight-based dosing in my institution, but to me, 30 mics per minute seems like a good dose to use through a peripheral. At my institution, 30 mics per minute, I'm placing a central line. I'm going to be honest with you on that. But data suggests that this could be safe for your patients. In the case of phenylephrine, that's the weight-based dose, and that's also the fixed dose of 95 mics per minute. At my institution, we use up to 100 mics per minute. And so, you know, you got to figure out what you want to use in your respective institution. Now, one of the places where we have a little bit of flexibility, and this is where there's no data whatsoever, but you could talk to your pharmacy colleagues, is what concentration of vasopressor do you want to use? Do you want to dilute it some more? Do you want to make it more concentrated? That's a balance that the data just hasn't explored at all. So that's somewhere where if you want to do some sort of clinical research, hey, look into doing this. Now, extravasation injuries are something that does happen, okay? And that's one of the reasons why we're so cautious with peripheral IVs and vasopressors through peripheral IVs. There is a classification system that just has 5 categories. This is all dictated by the NIH. Grade 1 is the grade that you just see a little bit of edema. It doesn't hurt. It's not red, just a little bit swollen. Grade 2 is when it starts becoming indurated, painful to the patient, but there's still no ulceration and no necrosis. That's stage 3. When you start seeing the ulceration and necrosis, that's when you call your surgery friends and you'd be like, I screwed this one up. You know, we need to do something. Stage 4 and stage 5 are catastrophic, leading to death, which is weird. Like if somebody dies from an extravasation, somebody was really neglected. Let's be honest on that. But nonetheless, when you look at the data, the highest incidences that you'll find in the reported literature of extravasation is between 2% to 5.5%. Guess how many of these percentages actually required some sort of intervention that was sophisticated? 0. So either it's not happening or people are not talking about it in the literature. I'll leave it up to you to decide. But nonetheless, we should be prepared. We should have protocols in place to protect our patients in the case that they do extravasate their peripheral vasopressors. See, we don't want to have cases like this one. This is a case report that was published, and it's a pretty gruesome photo, but some key components that we're not going to do in our respective practices, which is to keep it running for greater than 48 hours. But this patient didn't have the patency checked as often as they should have. The authors admitted that, you know, they could have done a better job of preparing the IV and keeping it nice and patent. But if somebody does have an extravasation injury, let's just go ahead and figure out how to manage it best. The first thing you want to do is stop the drip. Obviously, if this is causing the insult, press stop. Then you're going to go ahead and aspirate the contents, whatever medication might be still left in the actual catheter itself, and you're going to remove the peripheral IV. The other thing we should be doing is outlining the injury, making sure it doesn't extend any further, and then grab the phentolamine. Now, I can't quite get the answer as to whether this medication is on back order or not. I spoke to the pharmacist at my shop, and we have 5 vials left, so at least we have some at my place. Call our pharmacy, we'll transfer some to you if you guys don't have it. But what you should do is that you should reconstitute 2 of these vials, which creates 10 milligrams worth of medication in saline, and then you're going to go ahead and inject it around the area where the actual extravasation injury is taking place. Some data says that you should inject directly onto the area, and some data says you should do the perimeter of the area. I don't know what the true answer is, because thankfully I don't have a very good experience with this. It also says to use hypodermic needles, basically a 25 gauge or a 27 gauge syringe. You don't want to be stabbing your patient with an 18 gauge, because that's not going to be a good time. I mean, they're already pissed off at us because, you know, this happened, but nonetheless. And then some other data says that you should switch the syringes every single time you poke the skin. I think that's kind of overkill, but that's what's suggested. So you're going to inject the perimeter, and then you're going to apply nitroglycerin paste, about 2.5 centimeters, onto the actual area of extravasation. Make sure you vasodilate plenty and make sure that there's good blood flow. then we should figure out what went wrong. Did somebody skip a step? Did we not do an ultrasound guided IV? Did we keep it in too long? Did the concentration of the medication get too high? What could we do better so that we don't cause injury to another patient? But overall, I thought that this talk was going to be a little bit redundant, given that many of us already use peripheral IVs and peripheral pressors, and we've been doing it for so many years, but it turns out that I've learned about a lot of institutions that don't do this. So if you're going to start implementing this at your institution, just start with a protocol. I'll be happy to provide you with whatever data you might need in order to support your cause so that you could start using peripheral vasopressors at your institution and hopefully cut down on the amount of central lines that you place. Thank you very much, everybody.